Thank you, Olya, and to Di and the team for inviting me. And good morning, everyone, and good morning to the people on Zoom. So I'll be building on Connor's presentation, and what I'd like to do is overlay a linguistics lens on working in health professions, education and teaching communication. So my background, I have a PhD in applied linguistics, and I've been in education. I work in the medical education. So I have two worlds interlocking in this conference, so I'm in my happy place. So some of the key ideas I'd like to talk to you about in this presentation is, the first is, much of healthcare is facilitated through talk, interactive talk. We use talk to diagnose, make treatment decisions, carry out treatment, coordinate care, hand over care. And we do that, as we heard yesterday, in dyads and in triads, teams, interprofessionally and intraprofessionally. So for regulatory and accreditation bodies, the quality and safety of healthcare discursive practices is paramount, and this necessitates cycles of review and improvement and continuing professional education. So for us, this is really good, these cycles of review and improvement. Healthcare communication is the established term we use to refer to these discursive practices, so the ones I've mentioned above, or communicative practices, if you're more comfortable with that term. And these tend to be conceptualized, this is my opinion, through a psychological lens as behaviors, things that we do with talk, which are teachable, standardizable, for example, through protocols that we might use in clinical care. And they're also measurable, which is important for assessment. It's also the lens which predominantly informs health professions education. And I'd just like to distinguish between, some of the work that Kirsten was talking about this morning is more in health communication in the public health domain. And this is informed by public health discourses, risk communication, health promotion, the social determinants of health, and those sorts of things. And I think we've mostly been talking about healthcare communication, and in medical education, teaching clinical communication, we mostly talk about healthcare communication, but I think we also need to talk more about health communication, so public health discourses, because those two worlds absolutely interact. Other key ideas, this notion of bringing a linguistics lens on healthcare communication and thinking about language in the context of the text we use, and the types of interactions that we're involved in, and the context in which that happens. So Connor was talking about the rainbow. I'm going to use that image as well. So very diverse context in which we work. So discursive practices of healthcare involve multiple text types across different contexts, modalities, so spoken, written, online, and they're co-constructed. We work together to create texts. They're intertextual, so you might be talking with your doctor, patient talking, and you're both on a computer. So, and you could be informed by the text in front of you, spoken, but also working in, written, but also working in a spoken mode. So that's this intertextual, and there are distinctive patterns of vocabulary and grammar. The second thing is, we can look to theories of language, social semiotic theories of language, and all the semiotic meaning there is really, if you think about meaning, making meaning through language. And these can enrich understandings of discursive practices of healthcare when we focus on meaning, both effective and safe practices, as well as those that are less so. They can provide evidence of how they are enacted. So what do people actually do? What's going on? And linguistics can help us there. And that can also allow us more critical approaches. So what I want to look at is gaps and opportunities for change through collaborative multidisciplinary education. And I'll be drawing on some research with examples from team communication and rehabilitation, student-led hearing assessments. So even though my context is medical education, some of this is relevant to health professions education, not just medicine. And if I have time, to look at a medical handover. So some cheat sheet words for you, for those that might not be so familiar with linguistics. When I say discourse and discursive practices, I'm really just talking about patterns of language use in context and acknowledging that some of this knowledge can be tacit. So, for example, when we go to the dentist, we all know our roles, and we might not be able to explain the type of language that we use in those interactions, but we have enough tacit knowledge that allows us to contribute in ways that the interaction can be successful. Now, this thing called the discourse community is thinking about participants, text, and knowledge building and sharing practices. Important thing to remember, they're not always homogeneous. And there's a lovely quote somewhere that talks about discourse communities as being heteroglossic, so many meanings, sites of contention. And sometimes when I'm in meetings, I think that's what's going on. So another one is thinking about the apprenticeship. So we know in medical education, the apprenticeship model is really very, very well established, how students, future doctors, learn how to become doctors by looking at modelling from a more senior doctor who engages and scaffolds activity. So it's well established. But we can also use that apprenticeship model to think about how we learn to interact through talk. And this can be through scaffolding and feedback while the learner observes and engages and models those practices. And the final one, when I say genre, I'm really just talking about different text types. And these text types as a genre, they have particular stages and they're goal-oriented communication activities. So if we purchase something in a shop, we know how that interaction is going to unfold. And your goal is to get some help and buy that thing. And we use language to create that. So these are patterns of text genres that have predictable beginnings, middles, and ends. They're influenced by their context of situation and the context of culture, and they can affect the language choices of participants in predictable ways. So that's the teaching bit. Now on to the talk. So if we think about clinical communication, teaching and learning, certainly the strengths are that it's part of the core curriculum. And those of you who are older will remember when you were learning medicine that it was not always the way that communication was part of the curriculum. And there are consensus statements to guide educators on what ought to be in those curricula. It's clinical communication is absolutely informed by patient-centered communication principles and values. The teaching and assessment tends to be, as Connor has explained, experiential learning using simulation for skill development. It is assessed through OSCEs using simulated patients and also workplace-based assessment. Thinking about what are the gaps in that teaching. So the work of Silverman back in 2009, so one of the key authors in the Calgary-Cambridge Guide, said that what he said in 2009 is, I think, is still current. So what is actually taught is limited in the scope. It's very focused on the dyad of clinician-patient rather than more broadly thinking about those interactions, embedded in the pre-clinical years, so before students go into their clinical context, because it's more controlled, it's easier to do than the multiplicity of the clinical environment, focusing on student-patient interaction and neglects health written communication. So the teaching, if I may say so, is the emphasis on the student. Makes sense. They're the learners, but not necessarily on the patient at those early stages. Whereas in the clinical environment, the emphasis will shift to work-integrated learning of communications, where students are more likely to learn healthcare communication through interaction. What do I mean by through interaction? And this through emphasizes the dialogic nature of communication as a joint, interdependent activity. And I think many people have made that comment so far. It's also work integrated, importantly, and co-constructing or doing healthcare through talk, that is through talk and writing with more senior clinicians and other health professionals and patients, is extremely important for students learning. This is not a new idea. Walter Eppish, some of you may know, who works in simulation. He's a pediatric emergency physician, and he talks about how important it is for more senior doctors to scaffold their interactions so their juniors are learning through practice. And from linguistics, many of you will know the work of Bev Derevienko about learning in schools through interaction. So a number of people, even in this room, have linguistics backgrounds and are working in health professions, education. And here's some of the domains, so transitions, and Mary in the back there has worked with international medical graduates in Tasmania, transitioning to working in Australia, work in the curriculum, Tuan in the background over there, intercultural work, communication bringing in linguistics lens, and also in the research domain, making educators, helping educators become more aware from a research perspective what a linguistics lens might bring. So if we think about, so now I'm moving on to evidence phase, thinking about what are the gaps and opportunities. So if we look at transitions, when students move from being in medical school to their first year as an intern, it's a big step. If we think about the type of interactions that students might be involved in that first year as an intern, patient consultations, consents for procedures, family meetings, handover, referrals, multidisciplinary meetings, case presentations. Arguably, only the first and the last are really explicitly taught. Other things might pop up in the curriculum, but systematically, I believe it's the first and last receive quite a bit of attention. Even the case presentation, maybe not so much anymore. But what happens when students are interns while they're working, this second one, that referral consultation where the junior doctor is calling a more senior doctor advice, often by phone, is happening constantly, I would say daily, but we don't really do a lot of work in that in the curriculum. Consenting can often be left to the junior family meetings. So what the talk they're engaged in their regular work as interns is not really reflective of where we're putting all the eggs in one basket, if you like, in the curriculum. So then this is some work that a student, Julia Paxino, a PhD student, did during the pandemic when she had to be creative. She couldn't do her interviews as she wanted. It was via Zoom, thank you. And what she did through a review, first of all, she's working in rehabilitation context, and she was wanting to investigate team communication. And what she did from the literature, she mapped what the literature referred to was the interactions of the different team members in which they participated. So what she's really wanting to know is, did the speech pathologist go to the same team meeting to address the needs of this patient? Did that person have a voice? So she wanted to really map which team members participated, and she was guided initially from the review that she did, but she also asked people. And a lot of clinical work, the clinicians will know this, went on in this informal space, things like corridor chats. And she mapped those, and then in her interviews, she asked people, what do you participate in? And people were able to draw on their screen and say, oh no, not that one, yes, but I do this. So that gave her a good map of interactions for the different health professions in the rehab context of looking after patients. And so that discourse map allows you to think about in your teaching, do we talk about the context of that informal chat? So thinking about what we might address in the curriculum. This is a theory slide, so I've just got my theory slide in there. The genre one at the top is the types of interactions, that's my broad term that we can all understand, but for the linguists in the audience, we know that we can dive in more deeply and look at the language, grammatical choices that appear in those different contexts. Very briefly, and another study where the PhD student Samantha Tai, who's now finished, she looked at interactions in a hearing assessment context, audiology, and she video recorded those interactions. They were at two university hearing clinics. And so the clinical educator so it was a triad, student, patient, clinical educator, really had an educator role. So that was built into the job. And what she found in her work, she did a genre analysis, so predictable stages of the taking a history, providing a diagnosis, management planning. And she just looked initially at who talked. So as you expect in the taking a history, the student talked quite a lot, as did the patient, and the clinical educator very little. So when we got down to providing a diagnosis and managing planning, as you expect, the patient is speaking less, but still speaking. But the clinical educator has stepped in our 20 interactions, actually quite took over. The student would turn and say, "How am I doing?" And then the educator, or something to that effect, educator would turn and take over and end the interaction. Our final year audiology students, they needed to know how to do those other stages. So that's telling us in our curriculum, there were really gaps, opportunities to have sessions with those educators to say, how can we better involve those students in the planning and management phase? So that's where, by doing that type of looking closely and critically at what actually happens, it can help us in planning our curriculum. I won't talk about the telephone referrals, that will take too long. Moving to conclusions to make the chair happy. So I'm suggesting that these interdisciplinary collaborations, as we're doing here, can be very helpful for health professions education. Genre theory is one accessible approach for clinical educators to look at what's going on. But the language analysis aspect is really challenging. And we, as linguists, we have to think, well, maybe we do, I'm going to say it, genre analysis light, that it's accessible to our multidisciplinary audience. Excuse me. And well, I'm going to actually finish on this slide, because I love it. What it says at the top here, if I can just move this out of my way. What we also need to think about is really, the important words are missing. We need to think about the values that inform our research. So going to our teaching and learning in terms of not only the content, of course, but what are the values that underpin. So this is a mural in Vienna, done by school children, and I saw it while I was at a conference. And the first one is think of others. So when we're involved in these interactions, if we put ourselves in the shoes of the clinician or the patient or the family member and try and understand their perspectives and worldviews of these interactions. The second one, talking is important. Well, that's obvious, isn't it? This audience. And the third one is really about together we are strong. So in my presentation, I'm not saying everybody has to do genre or we have to do linguistics or a behavioral approach is not good. I think it's together we are strong, and have curiosity about other people's disciplines and what they can provide. So I'll get off my high horse and acknowledge the contributions. Oh, I can't move it forward now. Of course, this is not my own work, just my own work, but there's another slide with my colleagues and the references. I am down, nothing across. Click on the mouse. Oh, I see. Thank you, Luke. Acknowledgements and references. I'm very happy to share my slides. Thank you.